It's a very interesting question that we have in the field of urothelial cancer. Which patients respond better to checkpoint inhibition? For example, we have the Keynote 052 trial that is evaluating the activity and safety of pembrolizumab as single agent in patients who are cisplatin unfit, cisplatin ineligible in the first-line chemotherapy naive setting. Patients have not received chemotherapy for advanced disease but are unfit for cisplatin and received pembrolizumab at a flat dose. And overall, this trial showed an overall response rate of 29% that actually led to the FDA and EMA approval of pembrolizumab in this first-line space of advanced urothelial cancer. Of course, the question is, who are the patients who are responding better, and how can we develop, discover, and validate biomarkers that can help us identify patients who have a higher chance to respond to those checkpoint inhibitors. In that context, we went back and we evaluated the tumor tissue from patients who enrolled in the Keynote 52 trial, and we tried to evaluate a gene signature that it is present on the immunosuppressive environment, the microenvironment of the cancer, especially in the stroma. And we call this signature, this gene signature, TGF-β signature, because it was mainly mediated by TGF-β pathway, and also EMT, epithelial mesenchymal transition, because we think that this gene expression signature related to EMT might have immunosuppressive properties. So this TGF-β EMT gene signature in the tumor microenvironment, mainly in the stroma, overall in the tumor, might suppress the immune system and might correlate with lower responses to checkpoint inhibition. We did this biomarker study, and we saw indeed that patients who had tumors that had overexpression of this immunosuppressive signature, that high EMT TGF-β signature, they had lower response to pembrolizumab, as consistent with our hypothesis. We did one step further, and we also combined this suppressive signature with a different gene signature that is more immunostimulatory. It's an 18 gene signature related to interferon gamma pathways, and the higher this 18 gene signature score is, the higher the chance of the immune system to be stimulated, the opposite to before, and thus higher chance of response to checkpoint inhibition. And when we combine these two signatures, we call it the GP signature, the stimulatory, and the EMT TGF-β signature, we're able to separate patients to those who had extremely high response, if they have GP high and TGF-β EMT low, and vice versa. So had a very interesting data trying to tease out, separate responders versus not responders. Of course, these data are hypothesis generating at this point, are not conclusive, but definitely are very interesting and hopefully can be validated in other clinical trials and help us ideally define biomarkers that can help us select patients in the future for checkpoint inhibition. However, these data, despite how promising they are not practice changing yet, are mostly hypothesis generating, and I will work to generate the manuscript related to that work so we can disseminate the knowledge in the community.